Hi, my name is Dr. Tony Urbina, and welcome to Conversations in HIV. I am here with Dr. Maile Karris, and joining us from Chicago is Dr. Gregory Huhn, and we're going to be talking about some very interesting real-life cases of patients living with HIV. Today we're going to talk about a patient of mine who is living with HIV and also undergoing gender transitioning. But before we start on the case, let's hear a kind of video clip on this patient.
The way I perceived my risk for HIV was kind of, it was like a afterthought, if that makes sense, in my lifestyle. Like it was something I was definitely aware of, but I kind of willfully was a little bit ignorant of it, but mostly just I was always pushing it aside in my head because it wasn't something that was very like present physically in any way. When I was first diagnosed, I think it's important to say I was 20 years old. And so I had a 20-year-old mindset about a lot of things. So my immediate reaction was, am I gonna die? And that could like pretty quickly I learned that I'm not going to die right away, first off. And then my next concern was, okay, so how is this going to either reduce my life or reduce my like physical health?
So what do you think about his story about how he was diagnosed and his kind of initial response? Is it something that you've experienced with your patients?
Yeah, I mean, I think it's a very typical response. HIV, even today, even though one might assume that younger, persons who, he sounds like he was having some sort of, he knew that he was participating in some sort of risk behavior that put him at risk for it. I think that it's often an afterthought. So it's not so surprising to me. And his concern about, am I going to die? Or how long do I have to live? I mean, I've heard that many a times of a new diagnosis, of someone coming into clinic, even recently, because there isn't a lot of literacy necessarily about HIV unless it's part of your job, I think, or you know other people in your community that are living with HIV.
Yeah, no, I agree with that. And just, I think that perception of risk too is very difficult for especially young persons to gauge. So I kind of believe in like universal HIV testing, and then also really just talking about HIV prevention for those groups that are at risk. So let me go ahead and introduce a little bit of this backstory. So my patient was a cisgender heterosexual male. She now identifies as female. However, in 2010, she was diagnosed with HIV. She is a tobacco user, smokes about half a pack a day, and has been doing that for about 10 years. And she was started at that time on atazanavir boosted with ritonavir and FTC TDF. 5 years after diagnosis, she presented with intermittent ART adverse events and discussed transitioning to a woman with feminizing hormones. So she was on atazanavir FTC TDF. Her viral load was less than 50 copies, and her CD4 count was really robust at 940 cells. However, she experienced jaundice and hyperbilirubinemia. She did begin transitioning socially for about a year prior to this current visit. So, Dr. Karris, what are your thoughts here? Patient on boosted atazanavir, ritonavir.
I mean, it's a great drug.
Maybe was a great drug.
It was a great drug. I think these are conversations we have. Some of our patients are on these older regimens, and they're fine, and they're not. She's experiencing some symptoms, so clearly, and they're not just symptoms that are internal; they're external. So sometimes when our folks that are taking atazanavir experience some jaundice, it calls attention that they may not be healthy. And that itself can bring, additional discrimination potentially, or questions that maybe are not wanted at any period of time by different people. So I think it makes sense in this context when you have an external manifestation of an antiretroviral therapy side effect. yes, this is probably time to consider a switch.
Yeah, yeah. So let's hear from the patient, but I think the patient had very similar sentiments. So let's hear from the patient.
And one of my medications, it was raising my bilirubin levels. So that was creating like this yellowing, like jaundice-y type of effect. And that was really the biggest thing that affected my daily life. Was people would notice that, I would notice it, I would be self-conscious about it, and it would also sort of fluctuate. So sometimes it would be very minor, and then sometimes it would be like very apparent, and I had to sort of either kind of make up stories about it to other people because it's private and I don't want to discuss it.
So I think a lot of those similar
Yeah.
concerns, and just didn't really want to have that kind of stigma be so visible. And again, just concerns about looking unwell.
Yeah.
So really wanted to talk about maybe switching therapies. So again, patient experienced adverse events with this regimen of boosted atazanavir, but she also wanted to transition to a woman with feminizing hormones. So I think for me, this was something new that I heard from the patient, but I think as patients kind of express their desires to transition, that we should be open to kind of gender identities and how they want to express themselves. So this patient did switch her antiretroviral regimens. So we kind of discussed options at that time and how they would or would not interact with the feminizing hormones. So a decision at that time was made to switch the patient to rilpivirine, FTC, and TDF, and then quickly thereafter to rilpivirine, FTC, and TAF. Okay,
Yeah.
So we just kind of changed the regimens, and the big concern was to eliminate any potential drug-drug interactions with the feminizing hormones. So the patient did start transitioning hormones with estradiol, also progesterone, and spironolactone, a testosterone blocker. And we really took this opportunity to really discuss kind of smoking cessation and tobacco cessation, because of the increased risk of estrogens with thromboembolic disease. So tobacco cessation is such a difficult conversation to have. Any good tips that you have?
I also have this conversation. We have a specialty gender clinic, so I don't have a lot of new starts now. But prior to that, it's interesting to me how so many of them would tell me, I don't care about the risk, this is who I am.
Right.
And if it increases my risk of having, a thromboembolic event or something like that, you can help me take care of that. And I'm like, well, I could kill you. But most are willing. I feel like nicotine replacement therapy is definitely very helpful, because at least that helps with the cravings. But one of the other things that has been helpful is helping them get into either a support group or some sort of additional behavior change type therapy, because it's so difficult, to change something that potentially you've been doing for a very long period of time that is maybe a primary coping mechanism in the context of HIV, transitioning, and all of these things that are pretty stressful life events.
Yeah.
I'm curious to hear about you, because this is an area that I feel like we can always improve on.
Right. So, I think some of the things, and I think you bring up great points, is almost like just a harm reductionist approach too. So things that you can do to maybe reduce harm. So some of the things, and we'll kind of talk a little bit about some of the kind of timeline for changes with the estrogen therapies. So we know that with feminizing hormones that, the changes don't occur immediately, so it takes some time. So here's kind of a list of kind of physiologic changes that occur. So with breast growth, starts to occur at about 3 to 6 months, starts to kind of have its maximum effect within 3 to 6 years. Then we have a list of other kind of timeline of changes. But specifically, back to your point with the thromboembolic risk. So, background in the general population that the risk of thromboembolic events is rare, 1 to 10,000 to 1 to 100,000. This is mainly derived from the menopausal literature. One of the things that we kind of discussed with this patient is if she continues smoking, maybe going to a transdermal estradiol, which is associated with less risk for thromboembolic events. We know that there is increased risk for venous thromboembolism and ischemic stroke compared to cisgendered men and women with oral 17-beta estradiols, and definitely increased risk with the ethylene estradiol conjugated estrogen. So those are really not recommended. We worked very hard for smoking cessation. We did try nicotine replacement patches, variable success with that. But we're continuing that conversation. But again, really a holistic kind of patient-centered approach where we really looked at harm reduction, consider the transdermal estradiol, and there's really not a lot of good data if like the use of prophylactic aspirin in patients can really reduce risk. I don't really think we have the data yet. And a lot of the data that we get is really extrapolated from cisgendered women.
Sounds like we need more research specifically for transgender women.
Absolutely, absolutely, yeah. So again, she was transitioned to rilpivirine, FTC, and TAF. And just as she mentioned, she was able to incorporate these feminizing hormones into her daily routine. So I just want to touch briefly on some of the concerns about drug-drug interactions. And I think what's really great is that with our modern ART therapies, I think it's less of an issue. So ARTs with the least potential for pharmacokinetic drug-drug interactions with gender-affirming hormone therapy. So all the NRTIs, entry inhibitors, evolizumab, maraviroc, and enfuvirtide, bictegravir, dolutegravir, raltegravir, NNRTIs, the second generation NNRTIs. Those don't really have any drug-drug interactions, so there's no dose adjustments that are necessary. So again, I think they're a good option for trans patients. Now, the ARTs that may increase concentrations of some of the gender-affirming hormones, so when we look at dutasteride, finasteride, testosterone, we see that Kobe-boosted elvitegravir and all the boosted PIs may increase the levels of these gender-affirming therapies. So again, we may want to decrease the concentrations. And then importantly, this patient was on a previous regimen that could potentially decrease the concentrations of the feminizing hormones. So boosted protease inhibitors and the first generation NNRTIs, because of their inductive properties, actually can decrease the level. So I thought for her it was a good switch and fit into her lifestyle and less interactions with her feminizing hormones. And then lastly, it's really important to also have just general maintenance health monitoring. I think with trans patients, it's important to take an organ inventory so that we can screen effectively those organs. Other kind of important health monitoring is bone mineral density. So providers really need to ask these very important questions about which organs are present and how effectively to screen. So how do you have that conversation? You said you do have a gender clinic, so is this built into your EMR or how?
This is pretty built in.
Okay.
You know, like we now have templated notes, you know, so we kind of go through this. I think a nice recommendation, the CDC, you know, put out the 5 Ps of taking a sexual history.
Yes.
And I think using that in just a very person-centered way, not asking out of curiosity, but asking for purpose.
Right.
And I think with the organ, you know, based inventory, I think it's important also to remember to do it longitudinally, you know, because people might have different organs if they're seeking gender-affirming surgery.
Excellent points, thank you. Okay, so, you know, not all patients that are transitioning want gender-affirming surgeries. We did discuss with my patient kind of any gender-affirming surgeries that they were interested in. So breast augmentation, she had expressed an interest, not vaginoplasty. So we did have these ongoing conversations. Again, transitioning is a spectrum, so they can transition socially. Then they can decide whether or not to start on gender-affirming hormone therapy that's more in sync with their affirmed gender. And so gender affirming surgeries are an option for patients. So let's hear a little bit from my patient about her thoughts about what it was like transitioning and some of the support that she had.
But I will say that what's interesting, as I came out as a trans woman, I became, at the same time in my life, I got more incorporated with like the queer community here in New York. And there's this really kind of incredible history of trans women who are positive, and they have really like laid out the groundwork for like someone like me or people that are like me. And that really gave me a lot of a boost as far as like I didn't feel alone or as isolated as I did in the beginning. I mean, it's a complicated issue because being positive is not, I mean, it's weird to say it this way. It's not, being positive is not necessarily positive in your life. But among trans women and the history of that community, they've found a way to really make it into something positive that gives support to each other. So that was kind of incredible to be in touch with that suddenly. And I didn't expect that.
I think she was one of my first patients that I kind of managed through the transitioning and things like that. So I think for me, what was important is just kind of being present, being connected, you know, affirming her desire to transition, supporting her on her journey. But also I think what was very important was also just addressing her other health needs. Are there other kind of issues that you see in the care of transgender patients that you think are important for providers to kind of, you know, think about?
You know, I have a couple things, but I think that's where you find the joy, right? When you're really just caring for the person in front of you. That's I think what is really beautiful about medicine is we have this privilege to be involved in such an intimate way in people's lives. And I think for us particularly, it's valuable. I think we tend to really enjoy it because it's what we do, you know.
Yes.
But as far as other pertinent things, you know, I think sometimes it's important to have an understanding that at different periods of a person's life, it may not be safe for them to be transitioning. So I've had some folks that have kind of detransitioned at least externally for periods of time. So one of my patients was kicked out of their house and they were homeless, and decided to kind of detransition for a period of time until their life became a little bit more stable.
Right.
You know, and so we were trying to support and identify areas where we could get some of those basic needs met so that they could live their best selves, their best lives. But sometimes it might have to go back and forth, just dependent on their own for their own personal safety. And I think that that's just something to be aware of.
Right. What have been your experiences with patients that have kind of expressed these issues?
We do have these patients that are in certain levels or certain spaces of their transition. And what we've been trying to build here in Chicago and certainly across our network of Cook County Health to expand gender affirming care is to build the drivers and the secondary drivers among all providers. I think it's very important that as we integrate sexual health histories and care among all our providers, that we offer the types of comprehensive, I guess, support systems, both from not only the medical side, but from the social work side, from the behavioral side, from the legal side, to really make this an inclusive environment for our patients, including within each clinic setting, gender affirming champions to make the care welcoming for our patients and to make their transition, which can oftentimes be fraught with certain stigma. Absolutely one of the goals, I think, for getting to zero, and this was for the Vanguard for San Francisco when they established their program, 3 benchmarks for getting to zero, which is 0 new infections, 0 deaths from HIV, and importantly, the third is 0 stigma. As we address these components for these patients that are transitioning and within their gender affirming identity, I think all these components are very important for the successful care among these patients and among us as providers.
So thank you for joining us in Conversations in HIV. I'd like to thank my co-host, I think, Dr. Maile Karris. and Dr. Gregory Huhn for really presenting really interesting and I think important cases for all of us who are treating patients with HIV.